important for psychopharm is I have a lot of patience. So, yeah, you do have to laugh. You do have to laugh. I'm glad you see it that way. No blood vessels today. So, one of the important things that I wanted, even though some of the other stuff I didn't zoom through, a lot of that you can read on your own, look at details, some of those slides. However, when it comes to choosing medication, if you were to do a consult in psychopharm, a lot of it has to do with how am I going to choose the right medication, right? And it all goes back to, okay, I start with, and this is my approach. I think it's a good approach. It's served me well so far. That doesn't mean that you talk to other psychopharmacology type person and they have a slightly different approach. For me, though, it is matching what I know about the brain and what areas of the brain, right? I've told you this a few times now. What areas of the brain, given the diagnosis, what areas of the brain are likely disrupted, and then what neurotransmitter systems in those neuroanatomical brain areas are likely disrupted. And then taking a medication that matches those areas and those neurotransmitters, and then taking into consideration everything else, like side effects, prior treatment response. Now, if you go into the APA guidelines that I posted, you'll see them talking about prior treatment response is so predictive that you can actually look at first-degree relative response. Now, if Dan Brazeau were here, he wouldn't be surprised at all, right? But if I wanted to treat you, and I didn't know if I should go in a serotonin reuptake inhibitor or venlafaxine, if you had a first-degree relative that responded very well to one of those, it skyrockets your chances for success. And most of these kind of studies are the population level, so I can't say anything about an individual person, but that's how predictive response is. And if you follow genetics at all, or if you're interested in genetics, I know there's a couple tutors in here, right? Jorge, right? You know genetics, right? So, say for example that you have the serotonin receptor gene that's slightly more responsive to medication than somebody over here who has a serotonin receptor that's not very responsive. Just making this up. But point being, response is huge. Side effects, significant impact on medication adherence in psychopharm. It's always one of the biggest predictors. You have a guy who's in his 20s, and you tell him you're going to put him on a medication that increases his libido. It might not go over that well. I had a student last year, one of your classmates, he was all irate. You know what I'm talking about? All irate about this. Like, how could any guy take this? I'm like, well, if you're depressed, that's the thing. If you're depressed, your sexual function is even worse than it is on an antidepressant feeling good. So, sometimes you have to pick your battle, so to speak. Women in weight gain. Trying to get young women, and especially in their teens, to go on an antidepressant that causes weight gain, good luck. So you have to match everything you know about the medication to the particular patient. All right. I talked about response. I talked about tolerability. Other medical illnesses, such as if you have a chronic alcoholic who has severe liver problems, are you going to give them a drug that's extensively metabolized in the liver? Probably not if you can avoid it. So you have to, in any case that you look at, especially in my section, you should be looking at all these clues. Anybody who does well in my section will tell you, there are clues embedded in the case that should steer you away from certain medications and towards other medications. It's as simple as that. And it's easy for me to say it's as simple as that. But that's the approach you should be thinking about. All right? Patient preference. Now, this was one of my most eye-opening experiences of all my training, back when I was training, was how much importance patient preference plays into this, right? The old model of patient compliance, where somebody just takes the medication because the doctor said do it, is gone. And it's now adherence. Have you guys heard these semantics yet? Adherence is that they're adhering to the treatment plan that you agreed to, and that they have a large decision-making capacity in the relationship. So patient preference is huge these days, that you want them on board. It's that model's gone of, okay, the doctor said do it, so I'm just going to do it. That doesn't work. We know that doesn't work. People don't take the meds, right? Some crusty old white guy in a white coat tells me to take my meds, and that's the end of the story. That just doesn't work. So now you have a treatment team, right, with a treatment plan, and you're part of the decision, and it seems to do better. And then cost. You can never avoid cost, right? Another thing I wanted to touch base quickly, we talked about the 4 R's in that study. We talked about response, we talked about remission, relapse, reoccurrence. This is another way to kind of break it down a little bit and fine-tune it a little bit more when you're thinking about which medication to choose and how much of a response that you had. And I'm about to show you a treatment algorithm of sorts that I put together that I talk about partial response. So what does he mean by partial response? I want you to think about, now remember, in the study, a response was 50% reduction in HAM-D. A partial response would be you clearly dropped the score, but you didn't quite get to the 50% mark. Maybe you had a 40% reduction in score. That's still not nothing, right? That's not a complete failure, but it's not the response criteria that most people accept. So partial response. So think about these definitions when I get to the algorithm. Now, this is an algorithm that I put together for DePiro. I don't know how well you can see it up there. And it's basically, it's like, it basically talks about different ways that you can go with this treatment. And there are, somebody asked me about treatment algorithms before, and I told you guys, there are no university accepted treatment guidelines, because I was looking at this the other day, and there are scenarios that you can always come up with that don't fit this exactly. But that's the way life is, right? So what I generally like about this figure is that it talks about, well, if you do get some response, well, first of all, if you get no response, let's start there, that's easy. If you get absolutely no response out of a medication, what do you want to do? Well, it's probably not bad to think about switching. And when you switch, it may not even be a bad idea to switch to something completely unique from what you just tried, right? That doesn't mean, and don't ask me why, because I don't have the answer. Nobody has the answer. If you don't respond to one serotonin reuptake inhibitor, you still can respond to another. Why is that? One of the mysteries that nobody knows. Is it have more to do with it getting into the CNS? Does it have more to do with selectivity? Like I told you, fluoxetine has a little bit of norepinephrine repertoire, not enough to be negligible. What is it about one versus the other? If you can answer that, you'll get a Nobel Prize. Because that talks, that goes to any drug. Why would you respond to this particular medication, but not to another in the same class? Anybody have any theories? What? It probably does. But what is it? What's the difference? What enzyme? What's your target?
If I knew that, I would have the Nobel Prize.
That's right. That's right. That's right. What target, right? There are, just to process serotonin, you could probably pick 100 targets, right? The problem is, we don't yet have the answer. The genome has not answered all of life riddles as it's supposed to, right? There still is, for those people who like mysteries, there still is, What's that? Yeah, well, some people, I'm kind of a believer. I don't want all, do you want all the answers? Do you want to know exactly how everything in the body works and take away all mystery of life? I don't know. It's one of those things that we're not going to get into. But, For sure, for sure. But what I'm saying is I could give fluoxetine to somebody who's, because fluoxetine presumably is like the other serotonin reuptake inhibitors, but it might be a little more activated, right? But you could take citalopram and paroxetine, that neither one of them are all that activating, right? And kind of take side effects off the table, and they get a response to this medication, but not to this one. But they're fairly similar in every way, shape, and form that you can see. So why did they respond? You could argue that, well, it was a sequential. They were going to be better anyways. You can start kind of teasing apart all kinds of arguments. The point being, you cannot say, I can say with absolute certainty that just because you fail one, that does not mean you're going to fail another within the same class. Once you start failing 2 or 3 in the class, right, then all bets are off. Okay, they're probably not going to respond to a serotonergic drug if they didn't respond to 3. Now, what happens if you get a partial response? Well, if you get a partial response, that's where you start thinking more about augmentation, right? If I get a 48% response, and in order to be successful, I only need 2 more points. You guys are, students generally like the point system and the numbers and what does it take to get to a 72 and all that stuff. What happens if I need to get to a 50 and I'm at a 48, right? What happens if I can augment with a little thyroid or augment with, you've probably all seen the Abilify commercials, an antipsychotic. I haven't even given you, because I don't have enough time, when I have the whole 8-week module, I can go on some more rants about different stuff like should they be called antipsychotics at this point in time? You can use them for refractory OCD, you can use them for refractory depression, you can use them for bipolar disorder. There's a whole thing on should you really call these antidepressants, antipsychotics. Remember I went on the little rant yesterday about the book chapter where I can't just say, well, if you want to learn about benzos, go to this chapter, this page. That's not how it works, because I can find benzo information in bipolar, schizophrenia, anxiety, depression, and so on and so forth. So these medications aren't just for one disorder. You just kind of have to know how to, when to use them and where. Right? Augmentation strategies, atypical antipsychotics, I just mentioned. Thyroid hormone, I mentioned. What else is in there? A couple minutes ago when I was giving that scenario, after you fail a couple, you may want to switch to a non-serotonin reuptake inhibitor. But what happens if you fail on a serotonin reuptake inhibitor? Could you switch right away to a non-serotonin reuptake inhibitor? Would that be feasible to you? Who thinks that would be feasible?
Then you need a washout period.
Washout period is completely different. Let's assume, just for the sake, because that's another, we can go there if you want, but first let's talk about medication to medication. If you fail a serotonin reuptake inhibitor, I just told you that it doesn't mean you're going to fail another serotonin reuptake inhibitor. So it would be feasible to go to another. Would it be feasible to skip right to a non-serotonin reuptake inhibitor? I have 1 no, any yeses?
So yeah, because, well, if you fail on one, then it should be assumed that whatever effect it had wasn't working, so it should be safe, because it wasn't what it should have been, assuming that whatever target it was going for was really the problem.
The correct answer is that you could, if you wanted to bail right away on serotonin reuptake inhibitors, there are other first-line agents. Let me say this. Every single antidepressant that makes it to market has been shown to be better than placebo. Every single one. Even trazodone, you can't dose it that high. So every single medication from an efficacy standpoint, purely an efficacy standpoint, you could use as first line for depression if they can tolerate it. Therefore, if they fail a serotonin reuptake inhibitor, it is feasible to skip right to a non-serotonin reuptake inhibitor if you so choose. It's also feasible to go to another serotonin reuptake inhibitor. Right? You have a couple different options if you have a complete failure. Now, let's go switch to partial response, and I'm telling you to augment, right? Augmenting is different. This isn't exactly where I planned on going, but now that I'm here, I'm gonna go with it. Augmenting with something like an atypical antipsychotic is not the same thing as combination therapy. All right? It's not the same thing as combination therapy. Who wants to tell me the difference? What's the difference between antidepressant, combination therapy, and using an augmenting agent? Yep.
Combination is the distinction. Combination therapy, having more than one med working with more than one mechanism of action, and augmentation is more than one med helping achieve one mechanism.
You're very, very close. So an augmenting agent doesn't have to necessarily be an antidepressant, like thyroids are antidepressants, but you're augmenting the response that you got out of the antidepressant. And you may be augmenting that response, the actual mechanism, or you may be working by a slightly different mechanism. You don't know for sure. Like thyroid, you're giving them energy, you're activating them. Maybe that activation and energy in combination with the mechanism work together. But that's augmenting using something that's not necessarily an antidepressant. Combination therapy is where you're clearly using, as you said the first time, if I heard you right, if I heard you correctly, two different antidepressants that have distinct mechanisms, so you're kind of trying to double up on your mechanisms, or even more than double up. There's a thing called California rocket fuel that Stephen Stahl puts out that talks about that's venlafaxine and mirtazapine. So think about all the different stuff going on with that mechanism. That's true combination, as he calls it, rational polypharmacy. All right? So you could switch, or with a partial response, you could augment. You could do combination therapy. Would you switch if you had a partial response? That's where I was originally going. Would you switch? Would you switch to a non-SRI? Or do you think it's appropriate to switch to a non-SRI if you have a partial response? You can't talk to me forever.
I would argue no. They seem to be the safest with the small side effect profile. So I would say that it's worth trying them with SRI or you need to try a different.
For a partial response.
Yeah.
See, now that's appropriate. Since people like, we all like black and white answers. It would be appropriate that if I got a partial response with a serotonin reuptake inhibitor, if I got a partial response, it would be feasible without augmenting to switch to another serotonin reuptake inhibitor in hopes that I would give them a better response, because it's possible, right? So somebody asked me, I think it was in one of the breakout sessions, about if this doesn't work, what happens in 3 months? Remember, I was all excited that someone finally asked me that. Who was that? Want to take credit? Yeah. So remember that if you went that route, in 3 months from now, if you switched and it didn't work, you can always take a different path. And that's what people tend to forget. When I say this is the best answer now, it doesn't mean it's the only answer, right? So if you did switch to to another serotonin reuptake inhibitor because you thought that gave you the best chance of getting another response, that would be appropriate. Now here's the kicker. If you have somebody on 8 weeks of a medication and you get a partial response, say 30-40%, it's feasible at that point, if you think it's an adequate dose and duration, to switch to a completely different class at that point. Now I tend to be in the school of thought, well, if you've gotten that far ahead, to augment, but it would be appropriate to switch. Right? So you kind of have to read between the lines carefully on these kind of algorithms. The only incorrect answers are if you completely skip all first-line agents and go right to a monoamine oxidase inhibitor. Or you skip all first-line agents and you go right to a TCA. Or you give the most serotonergic medication you can in a 24-year-old white male complaining of sexual dysfunction. Right? There are going to be other clues. That's where you go sideways and are incorrect. Before that, though, just in efficacy, you have different options, and you can switch. Again, I come from the school of thought that if you get a 4 to 8% response, I don't want to lose 48 and start over. I'm going to augment first. But if you had somebody in here saying, well, I hate polypharmacy at all costs, I'm willing to take the chance of losing the 48% to start over, that would be feasible. You see the difference? It's very, like I said, it's not a black and white issue. So if you have questions on this before we move on to OCD, this would be the time while we're here talking about it. primary
And
scales.
also be considering the quality of life of the patient.
Yeah.
When you're treating the patient, you're not treating the HAM score. So you could have a partial response and continue using that drug if the patient is getting better.
For sure. Right. And that's where, that's a good question, because that's where I would say, well, that's where patient preference comes into it. I can have all the fancy algorithms in the world. If you were to present it with a case where the patient's like, listen, I am much better than I was, and I come back and say, yeah, but we only got a 48 on the HAM-D for Mondris, and they say, I'm a lot better, call it a day. That's why patient preference comes in. So you have to put all these factors in to your treatment algorithm. So very good question. Ready to move on to OCD? Okay.
First we answered from the computer. It says like 20 minutes.
OCD. Okay. Obsessive compulsive disorder is the first anxiety disorder we're going to talk about. I know at least one of you is familiar with the DSM-5 because you asked me about it before. The DSM-5 is coming out soon, and actually there was some talk of moving obsessive compulsive disorder into its own realm of obsessive compulsive impulsive disorders. Because, again, OCD is the first psychiatric disorder that we have where we could actually document changes in the brain and actually show that psychiatric illness wasn't just in your head or weakness or poor parenting or, again, I don't know when the actual cutoff would have been between, okay, it's all in your head to now we accept that some of these are illnesses, but wherever that was, it was OCD. That's when people stopped thinking, okay, it's your mom's fault, it's your dad's fault, all those things, and that it was all psychosocial, etc. OCD, you can look at changes in the brain that we'll talk about in a minute here. Prevalence is about 2 to 3%, so it's not anywhere near the prevalence rate of something like major depressive disorder, but 2 or 3% is not a small number either. 2 to 3% is 100 of you. That would mean that if you were representative of the U.S. population, that 2 of you would have OCD, and 20 of you, remember, close to 20 of you would be depressed. Approximately 10% of you would have a substance use disorder of some kind, and some of you would have both within those prevalence rates. Remember? So you got to start thinking about where these fit. Very high comorbidity with OCD because it is such a, as you'll see, has such a negative impact on functional person's functioning and quality of life. And we're going to talk a lot about with OCD. There's an overactive front part of the brain. So what is one of the logical ways that we all know about to slow down your brain? Alcohol, right? So OCD, alcoholism is overrepresented in OCD. 15%. Now remember, 10% of the population is a substance use disorder. That includes all substances. 15%, I'm telling you here, of OCD patients would have alcohol dependence, which is nearly double the general population. So that's a huge difference. Early onset, negative impact on the quality of life, as we talked about, and there are different subtypes. Like the MTV show, Hoarding, right? Who's seen Hoarding? Hoarding is the most difficult subtype of OCD to treat. It doesn't respond well to medication, it doesn't respond well to exposure, it doesn't respond to prevention. Of all the subtypes of OCD, hoarding is the most difficult. That's why it's so severe and they can have a show about it, because some of the other rituals aren't as exciting when you be treated. Is that like a collapsible bladder? Can you take that on a plane? With all the regulations and such?
I've tried it. Going on one if you want.
Yeah, let me know how that goes for you. Unless you get in trouble. I have nothing to do with it. Okay, so OCD, obsessive compulsive disorder. You notice on my attention span. My attention span's not the greatest. I need some norepinephrine to my prefrontal cortex. Right? So OCD is, what did you say? Are you laughing at me? You can laugh with me. If you laugh at me, you're going to get in some trouble. I'm telling you right now. Abnormal hyperactivity of the frontal lobe is what we're thinking about with OCD, right? And I'm going to explain this in further detail over the next couple slides. But first of all, you should be thinking right away, hyperactivity in the frontal areas of the brain. What does that mean? The easy thing, this is a nice, about as black and white as it gets in psychopharm. Every single medication with known efficacy in treating OCD has a serotonergic mechanism. We know undoubtedly that if you augment serotonin function, you can dramatically improve obsessive-compulsive symptoms. Dramatically. All right? It rarely gets that black and white, ever, in all of psychopharm. Again, this was the first, that's why people are almost considering it more like a neurologic disorder, because there are such clear mechanisms in the brain that are improved with serotonergic medications. And psychosocial with CBT, which we'll get to in a minute. So, remember the autoreceptors, because that's going to keep coming back again and again in the case of OCD. As with depression, that maybe it has something to do with taking the brakes off of these neurons and allowing them to fire and communicate more efficiently. We're going to revisit that again, but it's going to be a common theme. You should always be thinking, if I give a medication with serotonergic activity or noradrenergic activity, what am I doing to both the presynaptic and the postsynaptic receptors, autoreceptors and postsynaptic receptors. In the case of OCD, one of the theories is that maybe you are correcting it on the presynaptic side, but we're going to flesh that out a little bit here in a minute. All right? Hold that thought. So I've given you 4 areas of the brain that are implicated in OCD: orbital cortex, cingulate gyrus, striatum, and thalamus. Now, there's a book called Brain Lock. It's one of my, of all books on all mental illness, the best book I've ever read is probably Brain Lock. I think the author might have OCD. I used to work at McLean in Boston, and the president of that hospital is pretty good friends with him, and I think he told me he had OCD, but that could have just been my interpretation of the book, because he writes it in such, like, you believe he must have it because he writes it like, oh my God, the insight this guy has on this disorder. So I can't remember if that's my imagination that he told me he had OCD, or just me thinking he's got to have it. But it's that good. If you want to read a book on a disorder, in your leisure time in pharmacy school, Brain Lock. The cool thing about Brain Lock is it's about OCD, but it can be about anybody who has difficulty letting go. And pharmacists are classic for that, being very obsessive, being very, worry warts and all that. Brain Lock's a good book for anybody, really, that has trouble letting go of things and moving on. You get locked down to something and can't let it go. Yeah, I bet you that's a little. Yeah, see, I saw she's like, oh, yeah, that's me. That's a lot of That's a lot of. So we have arachnophobia here. This is like the dysfunctional row. Moving right down the aisle. All right, who's next? Oh.
You can go on about me. It would take a while.
Yeah, you fit multiple domains?
Oh, yeah.
All right. I'm not teaching bipolar or schizophrenia, so I'm going to miss out on some stuff, I feel. So, but you should be thinking about the overactivity in the frontal area of the brain. And the book Brain Lock talks about how these systems are all overactive in a way where Garlic, you asked me about projections. Here's the ultimate way to explain one of those projections. Serotonin comes from the raphe nuclei to a bunch of places in the brain. Remember? Serotonin is very diffuse. It doesn't have those very discrete tracks like dopamine does. It's very diffuse. It modulates other areas of the brain. One of the leading thoughts that's been pretty well documented with imaging studies and pharmacotherapy studies is that there's some kind of deficiency in the serotonergic system that's not slowing down this frontal area of the brain. the brain doesn't have this modulatory effect on it. So somebody with OCD, their brains just run wild in the frontal areas because there's none of that modulatory, like, quiet down type effect going on. What? No, well, it's not even just the synapse. It's no break on the whole. You're talking about neuroanatomical areas. If you image the brain of somebody with OCD, these areas are all like red hot on imaging because they're all firing. So at the synaptic level, sure, but it's even bigger than that. You can see these regions all together are just firing away. So you should think about it, yes, at the synaptic level, but in this particular disorder, you can think about it at the regional neuroanatomical level. Okay? Now, the orbital cortex seems to be your error detection circuit. So, a classic example would be someone is the oven, right? Because even without people with OCD would get this, where you make sure you turn the oven off. And then you walked away, and your error detection thinks, did I turn that off? And people without OCD would go back and they might check it once or twice. Right? Who's checked their oven? Or their iron? Or the lock to their apartment? I mean, everyone does this. That's because this OCD is normal protection mechanisms gone wrong. So, your error detection circuit thinks it picked up on something. The cingulate, the anterior cingulate, is the area of the brain that gives you that gut level reaction, like something's wrong. Now remember, a lot of these things are here to keep you alive back in the day, right? Back in the day. Sounds so ghetto, but I'm talking about way back in the day. Way back. What's that? Dark Ages. Even probably before the Dark Ages. If there is such a thing. I'm not a historian, but way back, right? So think about error detection. You get a gut level fear response. The striatum has, it's kind of like the automatic, that book Brain Lock does a good job of describing it as like transmission, right? Like, you're driving down the road, and then 20 minutes later you forget, you figure, how did I drive this far without thinking? That's because you have so many automatic behaviors, right? There's so many automatic things that you do every day. The striatum helps you coordinate the thinking and the movement to do all that stuff without even thinking about it. The thalamus is one of your primary relay stations in all of the brain, right? Everything goes in some way, shape, or form through the thalamus at some point. So if you have all these areas that are just overactive, basically the person is constantly detecting errors in their environment and getting the gut feeling of dread. And what do? They try to counteract it. You check the oven again, you check the oven again, you check the oven again. Somebody with OCD, because they just keep going through the same cycle over and over and over again, they can never get out of the loop. They're in absolute brain lock. They can't get out of the loop. They're going to check the lock. People, I don't know how much you know about OCD, but, people lose their jobs because they can't, they can't get away from the oven. My favorite story of all time, the pharmacy director at McLean was talking about one of the Harvard, who's the guy who gets valedictorian, gives the speech. He had OCD, and he was supposed to be giving his speech, and under times of extreme stress, all this gets worse, right? It doesn't get better, it gets worse, right? Well, he was going to give the speech, he was nervous, he went to the bathroom, whatever he was doing, and he got caught up with whatever ritual it was. I don't know that depth of the story. And he said, this guy didn't even come out. Everyone's waiting for this valedictorian to give his speech. He was stuck somewhere. It's literally stuck doing some ritual. Right? So this is obviously a smart guy who has some reasoning skills and everything, but was in brain lock to the point where he couldn't even give the speech. Right? That's going to cause some impairment, some functional impairment, some distress. This isn't just a little bit of, I better shut the oven 3 times and then I'm going to go to work or whatever. This is true lockdown we're talking about. So again, another visual representation of everything I just talked about. I like to keep the visual representations coming through. So here it's all about the Raphi nuclei releasing serotonin to the frontal parts of the brain. All right. Now, obsessions and compulsions have to be pretty severe, right? Because you guys were all in pharmacy school, so I can guarantee I can guarantee that you guys are overrepresented in neuroses and worrying and all of that. I can guarantee it. However, that doesn't mean you're overrepresented in true obsessive-compulsive disorder. That said, obsessive-compulsive disorder is not obsessive-compulsive personality disorder. Right? Has anybody heard of obsessive-compulsive personality disorder? Or they're very rigid people, everything's got to be their way, they micromanage. Right? I know, why is everyone looking at you?
I told you.
OCPD though, or OCD?
PD.
PD, right? You micromanage?
Possibly.
Are you rigid?
Yeah.
Not physically rigid. Yeah. I'm talking about rigid in your approach to managing. You're working in a group. Do people have a hard time getting you to budge? Yeah? Okay. OCPD is not the same thing as OCD. Right? OCPD, has anyone ever heard of the term, you were in psychology, you told me, ego-dystonic versus ego-systonic? You heard those terms? What's that? Ego-dystonic? How are you describing the ego-dystonic? Really? You work against yourself? Really? You kind of like self-sabotage, that kind of thing? So ego-dystonic is things that are kind of against your goals in life, right? If that guy that wanted to give the speech, to give a good speech is only going to help him, right? I don't know, maybe there's a recruiter in the audience, maybe there's a president of some company, whatever. His goals, obviously, if he went to Harvard, he's got goals for himself, I would be willing to bet. If he couldn't give the speech, that's ego-dystonic, meaning it doesn't go along with his goals and his life course, his life path. And I'm oversimplifying a lot of psychological semantics into a quick blurb. Ego-systonic would be things that are like obsessive-compulsive personality disorder. Some people could say, oh, that is, helps you with your goals. If that guy was OCPD, that means he would have had his speech prepared in a certain way, and that nobody could touch it, and you couldn't move it, and he had it just the way he liked it on the desk. It was centered up, it was lined to go. He didn't want any input from anybody. He knew what he wanted. That would be ego-systonic, meaning it's not exactly normal. Not exactly normal, but it helps you succeed in your goals, your life ambitions. It doesn't kind of crush you like OCD would. So, one of the most important things to think about with OCD is this is a product of your own mind. This is your own mind working with an OCD, your own mind working against you. It's not a delusion. A delusion is where, and you'll get to this in schizophrenia, a delusion is where you have a fixed false belief. This is not a fixed false belief. This is thoughts coming into your head, and this is where it gets really hard to explain, but if you really monitor your thoughts throughout the day, every once in a while you have thoughts that you're just like, you don't know where that came from, and you can't think of any something you interpret the wrong way, and kind of like, why did I interpret? Most people have those thoughts all day long, right? Because thoughts come and go, and you're integrating information, and you would just move on. Like, I don't know what that was, but I'm moving on. Somebody with OCD and brain lock, a thought like that takes on a life of its own. Like, well, what did that thought mean? Why did I, why did I have that thought? What does that mean? And they get locked on it because something's not right? The error detection circuit went off. Something doesn't match up. This is kind of a weak example, but I think it'll illustrate the point. You ever walking by and you see somebody who looks a little strange, or for some reason they kind of set you off the wrong way? They don't do anything. They don't do anything to you whatsoever. There's no reason to dislike them or fear them, but just something you're kind of like. A lot of people might have that error detection goes up, but then you quickly realize they have a little kid in their arms and they're drinking a coffee and they're not even paying attention to you or something. I don't know, something very benign. Pick your most benign scene. They're playing baseball, I don't care, whatever. But at first you were kind of like, somebody with OCD, the error detection goes off. and that's it. I don't care if the guy's got a cup of coffee and a kid and playing baseball, or the error detection thing gets set off. But the person knows that they're not being, a delusional person might think, that person's out to get me, and everything starts revolving around that delusion. Somebody with OCD knows that they're being unrealistic. This guy is not even looking at them, but they can't stop thinking about it. It's like anything where somebody tells you, oh, just don't worry about it. And you're like, I can't. I know it's not, I can't do anything about it. I just can't stop. And worrying is not necessarily the same thing as OCD. It's just a close relative, right? I mean, who in here is worried about something? And everyone's like, don't worry about it. And you're like, I just can't stop. I can't. That's more like OCD. Whereas a delusion is going to be, you believe that guy has something against you and it takes on a life of its own. Big difference. Big difference. That said, both OCD and delusions have some of their etiologic explanation in elevated dopamine in the front of the brain. What I didn't tell you was that overactivity in the front of the brain is partly attributed to excess dopaminergic activity that's not being mellowed by serotonin. I told you the serotonin is mellowing the area. Serotonin has modulatory effects on dopaminergic activity. Why is that important? When we get to treatment, I'll tell you why. Compulsions are all the behaviors designed to get around that error detection. I think something's wrong, I'm going to check the stove. The compulsion is the need to check the stove, even though you just checked it, and you're compulsively driven to check it again. Right? Because if you check it again, you get momentary relief that things in the world are okay, right? Because you are not going to burn the house down. The minute you walk away, error detection circuit goes, you got to go back and check. That's the cycle of OCD. Diagnostic criteria, they have to cause distress, I mentioned that. They have to impair functioning, I mentioned it. They're very time consuming. People spend a lot of time consumed in this whole cycle. Excessive and unreasonable, we talked about it. Now what can you do? OCD is highly treatable by two things, serotonin and by CBT, cognitive behavioral therapy. Cognitive behavioral therapy is things like, it's the most brutal, and in the case of OCD, it's the most brutal of all, you talk about archaic, you asked me if ECT was archaic. To me, this is even worse. If somebody has a germ issue or a danger issue, like say somebody has a fear of scissors because they have a pointy edge. What do you think you have to do in CBT? I have to walk around with scissors all day, every day, because the fear extinguishes. You literally extinguish fear by facing it. So you, the spider person, would literally have to walk around holding a spider all day long. In her bed, while she's brushing her teeth. It's not lovely, right? But that's what you do. And eventually your brain adapts, and it realizes that there's no fear, there's no danger here, and you extinguish the fear. You unlearn that circuit. Somebody with germs, I saw this woman when I was working at the hospital who was just standing there with her fingers on the glass in my office. And every day I'd come out and I'd be like, excuse me, and I'd be trying to come out of the office, and she would just be standing there like this, because she had a fear that, I think it went something like, she had there was a crack in one of her glass lenses, and somehow that developed into the glass was going to get into her eye and cause damage. So that eventually, if you feed the fear, right, like anything else, if you feed it, you end up getting taken over by it. She couldn't touch any glass. So every day I'd be like, excuse me, and she'd be like, okay, and she'd, hold the glass and just sit there, and she got better. She was discharged eventually. So CBT and serotonin. Thing I want to a couple things on this slide that I really wanted to zero in on. That I mentioned atypical antipsychotics here. I just told you that serotonin is the way to go. why would I mention an augmentation strategy of an antipsychotic? Who wants to guess? Even though you have not had antipsychotics, guess. Dopaminergic activity in the frontal regions of the brain. So if you do both, because they're not used in isolation, they're usually used as augmentation, you're usually increasing serotonin activity, right, coming out of the raphe nuclei, and at the level of the synapses you had suggested up here in front, and then by slowing down dopamine. So it's kind of a dual mechanism. But serotonergic mechanisms have to be part of the equation. They have to be. Other thing I wanted to emphasize here, I told you I rarely get caught up in dosing other than subtleties that you have to know. This is one of those subtleties. You have to push, or there's a very high likelihood that you will have to push doses higher than you would for depression in general at the population level. So you could see an 80 milligram fluoxetine dose for OCD, and that wouldn't be that rare. If you saw 80 milligrams for depression, you'd be like, how did they get to 80 milligrams? Because there's a ceiling effect of serotonin reuptake inhibitors because you can only inhibit so much pump. Remember? I told you guys you can only inhibit the pump so much. So there's a plateau effect. Well, with OCD, you're going to push that boundary as much as you possibly can. So this is an exception to my dosing rule where you have to know that you have to push doses in OCD. And then the last point on this, you do get a lot of partial and non-response. But I think people would agree a lot of that has to be OCD, you need medication, and you need the exposure response prevention. You can't just give a med and everything gets better, and you can't just do relapse prevention and everything is better. You might get a little bit better, hence partial response. Or I give somebody a medication, but they don't do any of the work. Every single time they check the oven, they're taking their medication and checking the oven. That's not going to work. You have to do the behavioral part, at least as part of it, and the medications help you to do the behavioral part. This is definitely a situation where both of them will help, but together, that's clearly the best option. That's not like depression where, sometimes you can do one or the other. In OCD, you're not going to do better than both. Any questions on OCD? Yep.
With the treatment, is there any chance for I don't use enough for say something overdose on it because of an error checking like it or either assessor compulsive use. They know that they took the medication, but instead if they did it, they're like a high incidence or anything?
Oh yeah, that's pretty interesting. That's a really good question. I've seen, if you look at studies like that study that we talked about, the Khan study, where they did an adherence of 80 to 120, that's because you do get people that are going to err on the side of taking too much. I've never actually heard of anybody like overdosing because they were OCD. I've actually heard the other way where people get so petrified that the contents of the capsules are going to touch like their food or this, that, or the other, that that becomes an obsession. I've seen that. I've never actually seen. So you're talking about like, I got to get it in my system, and they end up taking more than they should, right? Did I take it? I can't remember if I took it, so I better take it again. Good news is serotonin inhibitors are safe. And you can you have to push the doses off in OCD. So if you were ever going to have a disorder, that would be the one where
Not if you're augmenting it.
That's a different story, yeah. If you're augmenting it with antipsychotics and you're taking or benzodiazepines and you're causing problems, yeah, that's a different story. Yes. But good question. That'd be a good. That's going to be a future exam question. I think I like that. It's an anxiety disorder. So. Here's the thing. It's a very, it seems so obvious, but it's a very good question. That remember that every single time the error detection circuit goes off, you get that gut level fear reaction as if something's wrong. And the compulsion is, I have to do something to get rid of this fear that I'm experiencing, this level of anxiety. And in fact, the way that you measure how well you're doing, it's called a Y box, the Yale Brown Obsessive Compulsive Scale, where you say, okay, and you don't even have to have a scale, actually. You could do, all right, how much does it bother you to walk out of your house without checking the oven? Oh my God, are you kidding? I could never do that. And, it'd be the worst fear in the world, and I can picture my family burning, and, because remember, when the detections, you may have a thought walking out of the house about your family burning in a fire, but again, if you don't have OCD, that, even though it's a brutal thought, it's a normal thought that you may process that information, but no, I did this stove and move on. Monitor your thoughts. And you have all kinds of brutal thoughts that don't ever go anywhere. You get on a plane and you can picture everybody in the plane with their heads between their knees drowning, right? But you have a thought like that, but it's gone immediately, right? Somebody with OCD, they may have the plane or the fire situation where they start picturing it, and that causes such extreme anxiety. It's no longer even about the oven, it's about those images of their family burning or something instead, right? Because they've now processed this information and taken it to a whole different place. So for them, you measure the anxiety that's caused by that, and then you monitor how it goes down over time. And then, to tell you, it's awful to say, going back to the how archaic, or it's not archaic, it's highly effective. To treat somebody like that, what do you think you have to do to treat somebody like that? Say somebody pictures their family burning in a fire because they didn't check the oven, and they spend 3 hours checking the oven. What do you think that, to be really effective, what do you have to do? Come on, man. It's ridiculous. Someone give me a real answer. Yep.
Maybe like family photos or something, like burn family photos or something.
Well, you wouldn't actually have to burn anything, but you would have to write down, they would, or loop it in a tape, or visualize it constantly. My family is burning in a fire. My family is burning in a fire. They might write it down. They may say it. They're going to play the tapes back and forth. They're going to visualize it. And the anxiety is so incredibly intense at first, but if you do it over time, eventually that thought doesn't cause fear in you. Because remember, if something did happen, your natural instincts take over, right? The good thing about OCD is it's a product of their own mind. When push comes to shove, your natural instincts take over, right? These are just thoughts. These are thoughts that get out of control. So you extinguish it by constant exposure to the thought. And eventually, because they have desensitized to the anxiety, which was your original question, they've desensitized to that. The anxiety part of it, they don't have to check the oven again because the images don't cause them anxiety.
Why couldn't you just take them away from the situation and just be like, see, nothing happened? Let's say they're checking the oven all the time. And then you just like, well, let's just walk away from it, and then 5 hours later, see, your house didn't burn down.
Well, that's response prevention, though. Because for them, just because you remove them from the situation, they're still wondering if the oven's on. And they're still, because they're wondering if the oven's on, they're wondering if their family's going to end up burning in a fire. Yeah, sure, you may take some, they're going to go through an initial spike, and then they're going to desensitize. But it doesn't work unless you do it repeatedly. Because the next day when they go back in there again, it starts all over. It has to be something where they're repeatedly exposed to it over time. It doesn't work just once, if that's what you're suggesting.
I have a question on something different, though. If you do go into the ceiling to plateau with that, so they don't plateau on an SSRI?
Everybody plateaus. You can only block so much transporter, but with OCD, you're willing to push it as far as you can possibly push it. Whereas depression, there's a point at which you're like, okay, this isn't doing it. Whereas OCD, you may see more response, and you're more likely to, the risk-benefit of pushing the dose is better. Depression, if you're not getting a response at like 60 milligrams of fluoxetine after 3 months, you're probably time to move on. OCD, you're thinking, well, I still have a little bit of room to push the dose. I'm going to keep pushing it, and then you see if there's any response. EMDR. Yeah, I've never seen it used in OCD. All right, so we better do panic. We got 10 minutes. Luckily for you, panic's very easy. I'm going to let you look through the diagnostic criteria, but I'll summarize quickly. There's the panic attack, which most of you probably have at least recognize what that means, the discrete period of intense anxiety. But more importantly than the actual panic attack is the surrounding time spent on worrying about having another panic attack. That's what really defines panic, that they had one panic attack, and now they spend a significant amount of time worrying about the implications of having another one because the first one was so awful, or the first two were so awful, or so on and so forth. A panic attack, very discrete episode of fear, intense discomfort, and it's associated with at least 4, and again, you can look through the DSM-4 criteria a little bit closer on your own. It has physical symptoms. Now, I don't know how many of you have practiced in a clinical environment, but it used to be very common for somebody to be worked up for a heart attack when actually they were having a panic. So in modern day, when you go into an acute setting, they will actually rule out panic as part of a cardiac workup because they look so much alike. Difficulty breathing, trembling and shaking, nausea, fear of dying, dizziness, choking, smothering sensation. It looks like a heart attack if you don't know any better. So you have to rule out panic disorder as part of a cardiac workup in an acute situation. Well, you're going to start, cardiac issues, you can get lab values. For example, CPKs and things like that. You guys won't have cardio until next year, but there are cardiac muscle breakdown products you can measure, for example. Getting a history. If I start talking to you and you start saying, where's my Klonopin? Klonopin for what? Oh, I have panic. So there are clues during the workup, but then there's going to be lab values that you can do as well. I'm going to let you go through some of the characteristics. Prevalence is similar to OCD, around 2%. It's more often diagnosed in women. So like depression, panic disorder is not gender neutral. It's actually more common in women. Again, I want to get to some of the med stuff done before we end. Here's another dosing issue. We're going to start talking. The med treatment of panic is very straightforward. Serotonin reuptake inhibitors are going to be first line, right? And then TCAs are going to be second tier. Now, I'll say as a caveat to that serotonin norepinephrine reuptake inhibitors are being used for anxiety disorders as well. But if you think about norepinephrine and what it does, it's not always the best idea in someone who's already got panic, right? And what I mean by that is, if you activate somebody with panic disorder and they start to feel activated, do you think that's a good thing? Right? If you activate somebody with panic disorder, how do you think that's going to go? Well or unwell? Unwell. So you generally aren't going to, SNRIs aren't going to be your first choice when you have serotonergic medications. They're going to be slightly activating at first, if you remember, but not like adding norepinephrine on top of it, right? It's mainly due to you're waiting for the receptor sensitivity genes with serotonin reuptake inhibitors. So with serotonin reuptake inhibitors and TCAs, the biggest thing you have to watch out for is you have to go up on the dosing slowly, very conservatively, because you're petrified of inducing any kind of activation that can be misconstrued by the patient as panic-like symptoms. All right? So this is another dosing issue where you better be going awfully slow. However, in the end, you may end up at similar doses. It's not like OCD where you're going to push the dose. You're going to end with similar doses as you would with depression, but you're going to get there much slower. Has anybody ever seen someone have a panic attack? It's awful, right? I mean, it's horrible. It looks like they think they're going to die. And because they think they're going to die, you think they're going to die. It's not a good situation. Then they spend all that time worrying about it again. So you have to be very conservative with your medications. With serotonergic medications. Now when I talk about benzos, this is a case, another dosing nuance, where you may have to really load up somebody on a benzo. Because that, if you feel like you're going to die, you can imagine how compelling that would be, right? To have anxiety about it, right? That would be a pretty compelling. You're all going to notice a panic attack, right? You're all going to notice this. It's going to cause you. It's going to leave a lasting imprint on you, guaranteed. Therefore, serotonergic drugs may not be enough. You may have to go with benzos, and not only benzos, you may have to go with very aggressive benzos to even get these people out of the house. So, 2 dosing nuances: be very conservative with your serotonergic medications, be even more conservative with your noradrenergic medications, and be very aggressive with your benzos. Potentially. Doesn't, it's not one size fits all. But you may potentially have to be more aggressive. Miscellaneous symptoms, you may end up using as an adjunct some kind of beta blocker just for the physical symptoms, because a lot of this revolves around somebody having physical symptoms. So if you ever given a speech and you feel your heart racing, and the next thing you know, you feel your ears getting hot because your heart's racing, and it kind of takes on a life of itself. Most people have experienced that at some point. Well, panic disorder is like that gone to extreme. So you may use a little bit of beta blocker just to, like, as an example, atenolol. A lot of musicians use atenolol for that same reason, for stage fright. You might use a little bit of atenolol for what to them is kind of permanent stage fright, right? Where anytime you get those physical symptoms, they may take a life of their own, take on a life of their own. All right, I motored through that because it's pretty straightforward. So that's OCD and panic. Depression. Tomorrow would be GAD. And I was going to see if I could dig up a case. Somebody had asked me for a case, so I can give you one of those tomorrow. I think the only loose end is I want to build some kind of, I don't know if it'll happen for this year, but build some kind of glossary. You guys asked me so many questions on, well, there's a difference between glossary and spelling out abbreviations. But it's a twofold thing. But if you go through the chapter and the lectures, I think tomorrow, if there are any definitions or abbreviations that you don't understand, we'll have some time tomorrow as well to walk through those. Can anyone think of a definition or an abbreviation that I've talked about that you're still kind of fuzzy on? Or have they mostly been spelled out at this point? Yeah, because I think next year what I'll end up doing is, make either one of 2 options: making some kind of glossary churn, or use less abbreviations. That's hard to do in slides because you're not making them too cluttered. But anything else? Yeah.
You said SSRIs and TCAs are first and second tier. Where are the benzos on that?
First.
First, okay.
Chance. When do you know which to give? It's going to be very specific to that person. They're both giving a serotonergic drug and giving a benzo are both going to be reasonable. However, one you have to wait for, serotonergic medications. This is an important point. I'm glad you asked this. Serotonergic medications or antidepressants across disorders, you always have to wait for receptor changes. Benzos are immediate, right? So benzos are immediate. Serotonergic, noradrenergic, antidepressants, you have to wait for a lag time. So that generally plays into it. You may start with both, but eventually you want to try to get rid of the benzo. That would be a reasonable approach. Good question. Yep.
Could you then, if you do the dual therapy for the panic, couldn't you just give them like a higher dose of benzo and start right out with a higher dose with like SRIs?
You could, could, but the thing is, either way, you're going to have a lag time. So why wouldn't you take your time getting there? Because either way, as you start giving drug, you're going to start getting receptor changes. If you load on a bunch of drug, and now you're using the other one to not only counteract the disorder, but counteract the side effects, it's kind of risky. Because you have time either way, right? Now you may, I think a more appropriate way to do it would be to be more aggressive on your upper dose titration. Maybe you wouldn't be as conservative. You wouldn't crawl up with the dose because the benzo was there. But you wouldn't load because that would be very risky. Right? Because then the benzo is kind of doing a twofold. How much benzo are you going to need to cover all that? You know what I mean? But you could be more aggressive. I think that would be.
Could you do benzos only PRN and nothing else?
Yeah, I mean, they're done PRN, but the problem is this: you don't just stop worrying about having another panic attack. That's the problem. You know, this is one of these things, if you look back at the criteria, they spend a lot of time. It's persistent concern. You know, it's not like it comes and goes. You know, again, that's why I was trying to emphasize that feeling of dying is probably pretty compelling. And can you imagine giving a lecture in front of 100 people if you thought that at any given moment I could start, like, you know, I'm thinking, you know, if I don't have panic disorder, but how compelling it would be. It's not going to be PRN. I have a lecture today. I have a meeting tomorrow with colleagues. Well, there's always something going on that you're probably going to be nervous about if you're worried about having another panic attack. I mean, if you're sitting at home by yourself and, you know, watching TV all day, maybe you could get away with that. But most people who are trying to function could do it. But it's not impossible. You know what I mean?
Is there a high alcoholism rate in people with panic disorder?
Well, remember, all psychiatric illnesses, they're overrepresented in each other. All psychiatric illnesses. OCD seems to be particularly bad because you're literally, alcohol is an effective way, right, to slow down frontal lobe activity. So it's like a good situation going back. You have the disorder, and then you treat the disorder, and it really does make sense pharmacologically, but then you become dependent on that. Whereas some of the other disorders, it's not exactly, is alcohol the best way to squash fears, you know, generalized fear of having a panic attack? It's not as discrete. It's not that, you know what I mean? You can't pin it down to just serotonin and dopamine and discrete brain regions. You're talking about a generalized fear of dying that happened for whatever reason initially. Because, you know, who knows why initially this happened? I'm going to talk a little bit tomorrow in GAD about just an overactive fear response. You know, just like GAD, maybe you have an overactive fear response, maybe alcohol. Because alcohol is going to be overrepresented, yes. But not to the point of OCD. Or, you know, things, you know, yes. I will leave it at that. I'm getting too blathering on because I'm getting tired. Talking for an hour and 15 minutes straight, it's like, whew. Yes.
With the beta blockers, you know, you said that some use it for emotional resource fixation. They do it as just as needed thing just for that day, or and then if you can they do it for that, or would that be an adjunctive therapy?
Well, either way, I mean, you know, it was big when I was in pharmacy school. Part of our requirements where everybody had to give a lecture on Fridays, and it became a really big thing in my class. Everybody got a hold of atenolol because somebody had told us that year about atenolol works. You know, of course, we all tried it, and it works on your